Welcome to the RCI GDAS webinar, Alzheimer's 103, presented by Dr. Alfonso Martinez. Before we get started, let's cover a few conference details. If you have a question during the conference, we ask that you type in the question. Dr. Martinez may be able to answer your question as we go along. If not, all questions will be answered at the end of the conference. Also, if you are at your own computer station, a post-test survey will pop up at the end of the webinar. There will be 10 questions about the webinar and personal information questions such as your name and your email address that will enable me to send you your certificate. If you are not at your own computer, copy down the link that is posted on the last slide of the presentation. Use the link at your own computer to complete the post-test. Certificates will be sent within 1 week after the closing of the test. Please complete this test by the end of September 26th to receive your certificate. We are now ready to begin. I welcome Dr. Martinez.
Thank you, Elaine. It's good to be here with you again this morning. Elaine, we didn't go forward with the slides, but I'm going to the next slide. And are we good?
We are good.
Okay, excellent. Welcome, everyone, this morning. My name is Al Martinez. I'm a neuropsychologist in Peachtree City, Georgia, and Alzheimer's is one of my areas of specialty. For those of you that joined us for the last webinar, which was a month and a half or 2 months ago, the first few slides will be a brief review, and then we'll dive right into new material after that. Most of what I hope to talk about this morning is the treatment for Alzheimer's, but first I'd like to just introduce the topic by talking a little bit about what is dementia and what is Alzheimer's and how can we detect Alzheimer's. So are dementia and Alzheimer's the same thing? Well, they're close, but not really the same. Dementia suggests a decline in memory and other cognitive functions. The decline is enough to interfere with what we call activities of daily living. There are multiple causes for dementia, and we'll cover some of those causes, and primarily today, as you know, we'll be talking about Alzheimer's. The changes in dementia can be static, meaning that there's a change and then it remains at that level, and here we can think of a traumatic brain injury or a stroke, where immediately after the onset there is some degree of memory and other cognitive loss, but then there's no further decline after that. Of course, Alzheimer's falls under the progressive category of dementias. And there's something gone wrong with the brain. So dementia always implies that there are abnormal brain changes, and it is definitely not a normal part of the aging process. These are different types of dementias, Alzheimer's being the most common in individuals above the age of 65. Dementia with Lewy bodies is also fairly common. In fact, maybe 15 minutes ago I escorted out a lady with this type of dementia. She came with her children to get the results, and I hope at some point in time to do a webinar on this type of dementia. Frontotemporal dementia presents primarily with behavioral changes and personality changes. So this type of dementia, primarily as its name implies, primarily affects the frontal lobes of the brain and the temporal lobes of the brain. And so instead of seeing memory changes, we see personality or behavioral changes early on. Vascular dementia has to do with small strokes in the brain. It could be either a collection of small strokes, or it could be a single strategically placed stroke that has a significant impact on thinking. Alcoholic dementia, and then other types of dementias include Parkinson's disease dementia, and this is a dementia that oftentimes develops in more advanced stages of Parkinson's. Creutzfeldt-Jakob, which is also known as mad-cow disease, Lou Gehrig's disease, and then normal pressure hydrocephalus, which is a condition where there is too much what we call cerebrospinal fluid that accumulates in the brain, and as a result of that increased pressure in the brain, it adversely affects brain functioning. And this is a pie chart of the most common types of dementias. Alzheimer's is estimated to account for anywhere between 60 and 70% of all dementias, and Lewy body estimated at 20 to 25% of all dementias. Are you worried about Alzheimer's? What are the things to look for in order to catch this particular dementia early on? Okay, these are the 10 warning signs published by the Alzheimer's Association, and I think that these are reasonable. In a minute here, I'll give you my list of warning signs, but the way the Alzheimer's Association sees it, they say memory loss enough to disrupt daily life, which is how I defined dementia a couple of slides ago. It involves challenges in planning or problem solving, difficulty completing familiar tasks, confusion with time or place, trouble understanding visual images, new problems with words in speaking or in writing. And here I would encourage you to primarily think of word-finding problems in conversation. That's the language change that is most typically seen in Alzheimer's. So it's the most relevant in that that is what usually becomes apparent to family members, that the patient is struggling to get the right words in conversation. Looking at the next bullet for number 7, misplacing things, and importantly, losing one's ability to retrace steps. There's decreased or poor judgment, withdrawal from work or social activities, and changes in mood or personality. So those are all fine and good, and I think they're helpful, but I'll give you my 3 warning signs, and those being number 1, memory decline, number 2, memory decline, and importantly, number 3, memory decline as well. And so what I'm trying to stress in this slide is that the Alzheimer's Association 10 warning signs I think are extremely useful, but if our goal is to try to catch Alzheimer's in its very earliest stages, we shouldn't wait until people are showing changes in personality or changes in their daily habits, but rather are they forgetful? And this forgetfulness has to do with short-term memory, not long-term memory. So again, we're talking about not things that happened 40 years ago, but things that happened 40 minutes ago. That's where we can really do our best job in catching these problems early on in the individuals that we come in contact with. So what do I look for when I'm interviewing patients and families to catch the very earliest stages of memory loss? Repetitiveness is at the top of my list. There is rarely a case where someone is repeating questions or stories where they're not experiencing significant memory loss. I have seen in some patients, or I guess I should say in family members, who are under extreme stress and they're being pulled in all different directions, as is common for the caregivers of people who have Alzheimer's, who sometimes may ask me the same question again during a feedback session. And in some of those cases, it could be that the person is feeling so overwhelmed with what's going on that they might actually not be processing information that they're receiving, in which case they repeat questions. But again, by and large, if a person is repetitive, meaning they're asking the same questions again or telling the same stories, it's usually a sign of significant memory loss. Forgetting recent conversations or their details, forgetting recent personal events or news items, forgetting dates and appointments, losing or misplacing things, which again was one of the warning signs of the Alzheimer's Association, forgetting where things usually are stored. In the case of my father-in-law, who died of Alzheimer's 2 or 3 weeks ago, one of the things that we noticed early on, and that was 10 to 12 years ago, was that he was having trouble finding the corkscrew. And my in-laws had lived in the same home for 40-plus years, and he enjoyed a good glass of wine with dinner, and the fact that he couldn't find the corkscrew, although it was in the same place that it had been the previous 40 years certainly marked a change for him. So that's one of the things that I noticed that threw up a red flag for me. And then we all experience trouble remembering people's names. So if it becomes a more chronic problem and it marks a change for the individual, then we begin to think that potentially it could be related to Alzheimer's. And very importantly, and that's why I have it bolded, is the fact that these memory changes are not all or nothing. So the person with Alzheimer's is not forgetful in all respects, but they're increasingly forgetful over time. So sometimes I will have family members say to me, well, she remembers some things, and that's why I include this on the slide here, because I guess some people must be under the misconception that if you've got Alzheimer's, it means you can't remember a single thing, and of course that's not true. And when you get to that point, you might say we've missed the boat of opportunity to provide treatment early on. All right, so moving on to, we might say, the meat of this presentation. Question is, can we treat Alzheimer's? And the definite answer is maybe. And as I go over the next slides, you'll see what I mean by that. But before we talk about medications, I'd like to share some maybe principles of how you treat this disease. First of all, as most of you already know, we don't have any cures for this disease, so that the medications that we use, by and large, help the situation, but they don't cure the situation. And I think in being fair to family members, I need to always be straightforward in this regard. Which leads me to my next point, and that is it's extremely important to manage the expectations of the patient and the family so that they don't have unnecessarily high hopes that then are squashed when they find that the medication is not making all the difference. Medications do oftentimes make a significant difference, and sometimes it's noticeable by family members. But the goal with these medications primarily is to slow the progression of memory loss, which is a much more difficult thing for me to treat and diagnose as a professional or follow up as a professional. And certainly it's difficult for family members to establish in their own minds that the progression has slowed with these medications. So, what I liken to is it would be nice if these medications were the type where, you feel a pain in a specific part of your body, you take some pain reliever, and after half an hour if it's working or not, because either the pain still is there or it's gone. Obviously, it's much more complicated than that. It's important to treat this disease early and consistently, but in my opinion, not at all costs. In some cases, there are unmanageable side effects that crop up. Oftentimes with these medications, it involves gastrointestinal upset. And I should say perhaps 1 out of 10 people can't take these medications because it makes their stomach so upset. But 9 out of 10 are, in the end, able to take the medication. And then if cost is a burden to the family, the bigger picture needs to be considered. Because these are not cures, we have to take the bigger picture into consideration. I should also mention that I think all the pharmaceutical companies that put out these medications, for instance, Pfizer, which developed Aricept, I believe that they all have assistance programs, and so that if you're dealing with someone who doesn't have the financial resources to pay for this, if they can show that to the pharmaceutical company, oftentimes they'll either receive the medication for very low cost or they may receive it for free altogether. We need to keep in mind that the patient may be unable to manage their own medications even early on in the course of Alzheimer's. I encourage families and patients to consider becoming involved in research studies, and because where I am right outside of Atlanta, I often will use Emory as a resource, and I routinely try to send folks in their direction to be involved with research. And then there are beneficial lifestyle changes, which I will talk about, that we have good evidence to show that these lifestyle changes help decrease the risk of Alzheimer's. We don't know 100% what these lifestyle changes do for people who are already affected, but certainly everyone listening out there today can institute these changes to decrease their own risk of developing this disease down the line. So the cholinesterase inhibitors are medications that have been out now for a little while. Aricept first came out in 1996, then Exelon in 2000, and then Razidine in 2001. These are all similar medications in that they are intended to increase levels of acetylcholine, which is a neurochemical that we know is depleted in the brains of individuals with Alzheimer's. There are large-scale studies that have shown these medications to be effective in treating symptoms. They're similar, but they're not exactly the same to each other, so that if a person is either having a negative side effect to one of these medications, or they seem not to be experiencing any benefit from the medication, it is worthwhile to switch the individual to one of the other medications, because it may be that their brain chemistry responds better to one versus another. So again, although these are similar medications, they are not exactly the same chemically, and so again, if someone has a hard time with one for whatever reason, it is a worthwhile thing to have them put on another of these medications. And what they actually do, we're still trying to figure out. Well, we know that they increase acetylcholine, but whether they slow the progression of the disease or whether they alter the course of the disease, we just really don't know right now. What we know is that from a symptomatic standpoint, these are effective and worthwhile, so that the person who has Alzheimer's and is taking one of these medications will benefit in the moment. Their behavior, their memory, in many respects, they will function better while they're on the medications. But the question is, do they actually alter the disease of the medication? So do they really slow the progression? Or is the progression the same, except that at any moment in time when they're taking the medication, they are thinking more clearly than they would if they were not on the medication? Namenda came on the scene in 2004, and the nice thing about Namenda is that it's what we call an add-on medication, meaning that most times it's used to supplement one of the cholinesterase inhibitors. Those are the medications that I reviewed on the previous chart. When they first developed Namenda, it was meant to be used in individuals with more advanced memory loss. And so if some of you out there are familiar with something called the Folstein Mini Mental Status Exam, it's a screening measure that we use to examine memory. And 30 points is a perfect score, and the cutoff for memory loss is 24. So people scoring between 24 and 30 presumably are normal, and when they fall below 24, that's the abnormal range. And now that you have a sense of that, it was individuals who were scoring around a 15 out of 30 on the mini mental that initially received Namenda, and we know that in those cases Namenda was effective. And there are some studies to actually show that Namenda is not particularly helpful in earlier stages of Alzheimer's, but by and large, it still is used fairly liberally, meaning that doctors will prescribe Namenda even in earlier stages of Alzheimer's. And in my mind, that's probably a function of the fact that we only have so many tools at our disposal, and so why not use all of them and use them early on, which, you know, I don't necessarily disagree with, but the research is sort of lacking in what it can do in the early stages. Namenda works from a neuroprotective standpoint, meaning that it protects neurons in the brain from dying off early. And so, again, it supplements what the other medications do, and they can be taken in conjunction. Well, like I say in my next bullet point here, so it's usually taken in conjunction with a cholinesterase inhibitor, but in some cases, if the patient is unable to tolerate Aricept, Exelon, or Razidine, they may be put on Namenda singly rather than in combination. Results tend to be less robust with Namenda in relation to Aricept, but there are exceptions, and I see those exceptions in my office. I'd like to say regularly, but that might be stretching it a little. I'm thinking of a recent patient that I saw for a re-exam. So I had seen her a year before, diagnosed her with Alzheimer's, and then she was returning, and she had been started on Namenda a couple of months before I saw her back in my office, and both the patient and daughter felt that there was a real boost in the patient's memory when she started on the Namenda, and in fact, when she underwent the neuropsychological testing here in my office, she looked really pretty good. And so, again, everyone's brain chemistry is a little bit different, so a medication that may just have an okay effect on one person's brain may have a more robust effect on somebody else's. Now, let me talk about a couple of things that are under study right now for Alzheimer's. We understand what we call the cascade of changes in Alzheimer's brain. We understand that cascade really pretty well. And so because of research that's been done over the course of many years, we have a pretty good sense of chemically how the disease begins. And the advantage that gives us is that there are multiple points in this cascade that we might be able to intervene at before the brain starts to develop these depositions of plaques and tangles. And these experimental drugs, one put out by the pharmacy Baxter, and the other by Lilly, these both are antibodies against beta amyloid. And beta amyloid is what the plaques are made of that collect in the brains of people with Alzheimer's. So in other words, if we can control the production of beta amyloid by the brain, then we can potentially really change the course of the disease. Both of these agents have shown good results so far in what we call phase 2 studies, and those studies primarily are looking at the safety of the medication. You know, before a medication comes to market, it goes through several phases, and phase 2 is primarily to make sure that the thing is safe to begin with. And then phase 3 trials for both of these are underway as we speak. And so there's a lot of hope that maybe one of these agents will change the course of the disease. So for those of you who have family members who are affected, there's a lot of hope out there. And what I often say to families and to patients and families is that there are people worldwide working day and night to try to come up with a cure for this disease. And many of them are people with big hearts and who really want to do something good. For better or worse, because there are so many people who are affected by this disease worldwide, the pharmaceutical companies also see a tremendous profit motive in all this. And so for whatever pharmaceutical company ends up coming up with a cure, they have a lot of money to gain from this kind of a discovery. So for all different reasons, there's a lot of work being done on a cure for this disease. A couple of other things that are under study right now: resveratrol and flavonols, and these are substances that are found in red wine and dark chocolate. How convenient, huh? So I know that for some years I've been practicing good medicine by consuming a glass or two of red wine per night, and also consuming dark chocolate, of course in moderation. But there is good research so far to show that there may be substances in these foods and that may make a difference in terms of the course of this disease. So again, these are things that are under study, but I think that they're quite encouraging. Okay, so what are the common behavioral changes that we see in Alzheimer's disease, and equally importantly, how are they treated? At the top of the list is depression. There may be anxiety, there may be anger, aggression. As the disease progresses, we see apathy, which many of you know has to do with this feeling of not wanting to do anything and not caring. There may be hallucinations and delusions that develop, as well as agitation. And the hallucinations and delusions tend to be a feature of more advanced Alzheimer's. If you see somebody who is hallucinating, meaning that they're seeing things that are not there, they're seeing animals or people, or they develop delusional thinking, which often involves paranoia, fears of getting broken into, or fears that people are taking your belongings. If those features are seen early in the course of the dementia, then we begin to think of the other common type of dementia, Lewy body dementia, or dementia with Lewy bodies. Those features are seen earlier on in the course of Lewy body, but they're seen much later in the course of Alzheimer's. So that's an important differentiating point between these two types of dementias. So primarily I'm going to talk about depression. And depression is really quite common in Alzheimer's. Estimates are that anywhere between 30 to 60% of people with Alzheimer's develop depression. And there have been studies that interestingly have shown that older adults who develop depression for the first time after the age of 60 may in fact be showing the brain changes associated with Alzheimer's. So in an individual who has never suffered from depression earlier in life, if they first start to develop depression in their 60s, beyond the age of 65, it might actually also be signaling the beginnings of Alzheimer's. We think of depression perhaps in two separate categories. There's a reactive or exogenous type of depression, and this is a depression that develops as a function of things occurring in our environment. So the death of a loved one, the divorce of a son or daughter, financial problems, problems in the marital relationship. That's what we call a reactive depression because it's in reaction to something in the environment. And exogenous means outside of oneself or in one's environment. And the other type of depression that we talk about is a neurochemical depression or an endogenous depression. And this is related to chemicals in the brain that may be lacking, like serotonin. And so these are people who genetically are predisposed to developing depression. And so it's not so much a function of things having gone wrong in their lives, but rather that there are these chemical imbalances in the brain that are causing depression. And truth be told, in most cases of depression, there often is a combination of these two. So the truth of the matter may be that some individuals are chemically or genetically predisposed to becoming depressed, and it is those individuals who, under the right circumstances in their environment, then develop depression. In the context of Alzheimer's, depression tends to cause excess disability, as you might imagine. So if you have a person who already is experiencing significant loss of memory as a function of Alzheimer's, if on top of that you throw depression, then you are creating an individual who is much more confused, much more forgetful. And in fact, I remember reading a study a number of years ago that found that in the earliest stages of Alzheimer's, if a person was experiencing depression, it is possible that the depression would cause greater disability than the dementia. Okay, so again, you have in early stages, depression can be more powerful than even the Alzheimer's in terms of creating disability. And then this last bullet, I just wanted to mention, some of you may have heard the term pseudo-dementia, and that's usually used for someone who looks like they may have dementia, but in fact they do not. And so it's a common referral to me as a neuropsychologist for a primary care doctor or a neurologist to say, hey, I want you to see Mrs. Smith for me because I know that she has depression. That's obvious. She says she's got depression. And she also has some memory loss, and I want to know if her memory loss is simply a function of depression or if she's got the beginnings of Alzheimer's. And of course, the answer to that question may be, well, maybe she's got a little bit of both. Maybe she's got some depression and a touch of Alzheimer's as well. So these are some common signs of Alzheimer's, some common signs of depression in Alzheimer's. Oftentimes, I'll have patients who will express guilt, and this often comes in the form of saying, geez, I'm worried about my memory. I'm worried that I may be a burden to my children if I do have the beginnings of Alzheimer's. And many of us have probably heard that before. And it's not automatic that a person, that's a legitimate concern on the part of people. So not in all cases does that mean that the person is depressed, but oftentimes it does mean that there's some underlying depression. Then there's things that are more obvious, like crying spells, suicidal comments or thoughts, and indifference toward life. So when I'm interviewing patients, I always will ask them if they have thoughts of suicide. And usually as my next question, I will ask them, well, if you're not having thoughts of suicide, do you have thoughts that you would no longer care to live, or that life just doesn't mean as much to you anymore? And even if they're not suicidal, but they have these thoughts of indifference, that's usually a pretty good indicator that there's some depression there. Self-deprecation refers to beating up on oneself, meaning having low self-esteem or calling oneself stupid, or thinking that you're no good. Changes in appetite or disrupted sleep, inability to gain enjoyment. So here, particularly if I'm talking to an older adult and I'm asking them about depression, I will often say, how do you react nowadays if you hear good news about your grandson or granddaughter, if you heard that they got accepted to college, or if you heard that they got a good grade on a test? And one of the common features of depression is that people are unable to gain the same enjoyment from things that they once did. We also look for decreased energy level and fatigue, and then we also look for decreased initiative. And here I'm talking about a person's sort of get up and go. So like many of you have kiddingly heard, his get up and go has got up and gone. And this is a common sign not only of depression but of Alzheimer's as well, where people just lose their initiative. They may still enjoy engaging in certain activities, but it's the idea of even getting themselves together to participate in that activity that seems overwhelming to them. And I should say, of course, you folks will probably think that these signs that I'm talking about depression are not only seen in Alzheimer's, but we can use a very similar list if we're talking about depression in just typical adults who are not experiencing Alzheimer's. So what do we do about depression? The most common types of medications that are used nowadays are called SSRIs. That stands for selective serotonin reuptake inhibitors. These are by far the most commonly prescribed medications, and all of you will be familiar with some, if not all, of these medication names: Prozac, Zoloft, Paxil, and Lexapro. And these are extremely effective medications for treating depression. in the context of Alzheimer's, but also outside of Alzheimer's, of course. There's another class of medications called SNRIs, or serotonin and norepinephrine reuptake inhibitors. These medications are used a little less often, and they seem to be more effective in people who are not only suffering from depression, but also from some sort of a pain syndrome. And so they are effective as analgesics or pain relievers. And medications that fall within this class include Cymbalta, Effexor, and more recently, Pristiq. And then there's a class of old-time medications called tricyclic antidepressants, and these were introduced in the 1950s. By and large, these have fallen out of favor as a result of the side effects that they produce. For one thing, we found that although these medications tend to have an energizing effect on the depressed person, one downfall of that is that oftentimes they would just get enough energy to commit suicide. And of course, that's not a good outcome. And so that's one of the concerns with the tricyclics. And then if the depressed person tries to use these medications, not to relieve their depression, but actually to try to commit an overdose, these medications tend to be more lethal when you compare them to the other two classes, SSRIs and SNRIs. And a couple of the medications in this group are Elavil and Pamelor. So what are some non-medication forms of treating depression? Of course, there's counseling, and this is extremely appropriate in the early stages of the disease. And so if someone was not depressed, they're diagnosed with Alzheimer's and they develop some degree of depression around the diagnosis, giving them a medication probably won't hurt anything, and it might actually help something, but probably the more appropriate course would be to provide some sort of counseling. And at one point in time, counseling or psychotherapy was not reimbursed by Medicare, but they changed that rule, I don't know, more than 10 years ago. And the reason why they didn't reimburse is because they didn't want there to be abuses of a psychologist or other counselor providing counseling to a person with very advanced Alzheimer's. The contraindication there is that if a person has very advanced Alzheimer's, they're not going to be able to remember what happens during a counseling session, and they're certainly not going to be able to institute those changes into their everyday life, which is the whole idea behind counseling. And so I think Medicare was on good footing, but on the other hand, they've come around to recognizing that people in the earlier stages are able to benefit from psychotherapy. And then there's ECT, or electric convulsive therapy, and this is more appropriate for treatment-resistant depression. So these are people who have been tried on all kinds of medications. They are experiencing suicidal thoughts, and they're very depressed, and they can't get out of bed. And then ECT is not an unreasonable approach. I don't really know how often it's used nowadays because I'm not dealing with that population. And some treatment considerations. From a diagnostic standpoint, older adults are less willing to admit to depression altogether. They see it as a weakness and something to be handled within the family. Men are less likely to admit to being depressed, and when they are depressed, they more often present as angry, where women more often present as sad. And as the disease progresses, as Alzheimer's progresses, it's important to rely more and more on families' perception of whether a person is depressed or not, as their ability to be as the patient's ability to be introspective and think about their own feelings becomes diminished, as you might imagine, as the disease progresses. And as far as treatment for depression, I say careful with start low, go slow. This is sort of a mantra that physicians use, particularly with older adults. And it makes a lot of sense. And what it means is that when you start someone on a medication, you want to start them at a low dosage and then work your way up slowly, which makes a lot of sense considering that people's metabolism changes as they grow older. And the danger in that is that sometimes patients are started on the lowest dosage of an antidepressant, and they are never pushed up to more therapeutic levels. And so you have a patient who is taking, Paxil for 5 years at sub-therapeutic levels, and so here they have a medication on board that's really not doing very much for them. So that's what I mean with be careful with that approach. If you are a family member of someone with Alzheimer's, it's incumbent on you to lobby the physician for either a different medication or a higher dosage of a medication if it doesn't seem to be working. Oftentimes physicians won't ask once they provide a medication for depression. In their minds, they feel like they've already covered that base and now they don't need to worry about it anymore, when in fact they may need to worry about it. And the effects usually are seen in 6 to 8 weeks of treatment. So you should not expect a change in the person's demeanor in a matter of a week or two. There can be what we call placebo effects, where now that the patient knows that they're being treated for depression, that might boost their attitude by itself. Okay. And the question, can we prevent Alzheimer's? And again, definitive answer is maybe. There definitely are some things that we have found through research that help decrease the risk of Alzheimer's. Maintaining a high level of activity, consumption of a good diet, moderate alcohol consumption, and decreasing stroke risks. And I'll talk about each of these in a little more detail. So in terms of activity level, we're talking about exercise. We're talking about aerobic exercise, and that could either be, running, playing tennis, riding a stationary bicycle. We have found also that resistance or strength training may be helpful. So this is working with weights can actually be helpful for brain functioning. And then stretching, as occurs in I'm trying to think of the name of that Tai Chi, which is the Chinese form of exercise. Through yoga, stretching also has been found to be important. Mental activities, doing puzzles. In my mind, reading is one of the best things that you can do for your mind. Reading, I think, is challenging in that you have to keep a story in mind. There's characters, there's plots, there's subplots. And to me, when patients ask me, what can I most do for my brain when we're talking about mental activities, I say to them, read, and read often. Taking classes, foreign languages, musical instruments. And folks, I see a couple of questions that are being submitted, and because I'm near the end of my presentation, I'll be glad to address those in just a minute here. Social activities, getting together with other people, we know actually is healthy for the brain. Getting together for dinner with friends, becoming involved in the senior center in your area, getting involved with book clubs and other organizations, we know to be helpful. In terms of diet, I'm just going to, in the interest of time, I'm going to focus more on the Mediterranean diet. These are things, folks, that we all have known for a very long time are healthy and beneficial, and now we also know that they help decrease the risk of Alzheimer's. So where these things always have been powerful in terms of bodily health, now we know that they're also powerful in terms of mind or brain health. And Mediterranean diet usually includes fruits, vegetables, nuts, seeds, beans, and olive oil, consuming fish at least twice a week, wine, and there's typically a preference for red wine, and you'll recall that I talked earlier about resveratrol and other substances that might be specific to red wine that might be more beneficial. And then it's almost also limiting red meat and sweets. Alcohol we know to be helpful in decreasing risk of Alzheimer's. There is extremely strong evidence from around the world to show that moderate drinking decreases a person's risk of dementia. And moderate is defined as 1 to 2 drinks per night. And it's almost regardless of the alcohol type. There is some good research to show that there are similar benefits from drinking beer, from drinking white wine, from consuming hard liquor. And so there's something about alcohol that seems to be helpful, and with the way the research is going, we may find that red wine in particular is more helpful than other types, but that has not been clearly established just yet. And of course, alcohol consumption is not recommended for people who have either a personal history of alcohol abuse or a strong family history of alcohol abuse. We find that people who drink in moderation are at decreased risk when we compare them to teetotalers who do not drink at all, and they're protected in relation to people who drink 3, 4, 5, 6 glasses of alcohol per night. So it is just in that range, in the 1 to 2 drinks per night, where it seems to be helpful. All right, and let me just talk briefly about caregiving. I see my time is up, and I'll be glad to take questions in just a minute here. There are certain challenges that are unique to Alzheimer's in terms of caregiving. There's something called anosognosia, which means that the patient with Alzheimer's, oftentimes, they don't themselves recognize the degree of difficulty that they're having or the fact that they even have memory loss. And this is often frustrating to family members who so obviously see that this person is struggling, and they can't understand why the person doesn't see these problems in themselves. It tends to be a thankless job, meaning that I'll use the example of my father-in-law, who always was a gentleman and was wonderful with his wife, called her his bride in the 50-plus years that they were married, and he was always very polite with her. And as he developed Alzheimer's and as it progressed, there was never a time that I heard him say thank you for anything that his wife was doing for him, although she was doing practically everything for him. So. And then let me just share a couple of caregiving philosophies. Take the wheel. That means if you're the caregiver of someone with Alzheimer's, take control. Believe in yourself that you're making the right decisions. Take care of yourself before you take care of your loved one. So the equivalent of that is put your oxygen mask on first. Find time apart from that person. Find the humor in it. And let me go on to my summary here. So dementia is not a normal part of aging. Alzheimer's is one type of dementia. It happens to be the most common. There are several medications that are available for Alzheimer's. They're far from cures, but I can tell you that they make a difference. Depression is a common, you might call it, side effect or behavioral side effect of Alzheimer's. It's important to treat it aggressively because of the disability that it may create. And there's a number of lifestyle changes that can help decrease the risk of Alzheimer's. And the caregiving philosophies that I did not share in detail with you can be helpful in managing the burden of caregiving. All right, and with that, I'm done with my presentation, and I'll gladly take questions.
Okay, there is the first question on how do you work with a patient who is resistant to prescription changes because of bad experience with side effects?
Gosh, I was going to give a prize for the easiest question that someone would present, and that obviously won't get the prize. It's a good question. I mean, unfortunately, with many patients who have Alzheimer's, and this will depend on their level of impairment, of course, they feel that, like, they may not need medication altogether. So sometimes people are resistant to even beginning with medication. What I would do is usually use the primary care doctor. Hopefully there's a primary care doctor who's been on board for a number of years, from even before the patient started to develop dementia. And that person could potentially be instrumental in saying, hey, Mr. Smith, you absolutely need to change from this to that. And so I would put it back on the doctors and have them kind of do the dirty work. I don't have, I know family members who who tell little white lies and things like that. And I can't say that I'm 100% opposed to those kinds of approaches. If you're doing the right thing for the patient, unfortunately, you're not dealing with someone who is functioning at your same level and can process and understand things at the same level. So you've got to be creative and perhaps use a primary care doctor as a resource.
Okay, well, that's great. Dr. Martinez, we really do appreciate your time, and I wanted to let everyone know this webinar will be archived on the Rosalind Carter website. Just go to the Resource tab, and you will be able to view it again if you have any questions or you want a refresher. And remember to stay on for the post-test. Again, thank you very much, Dr. Martinez. Have a good day.
You're welcome. You too. Bye-bye now.
Thank you. Please stand by.